The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. I hope everyone is having a great start to, well, I guess almost great, getting close to the great ending of their Thursday. Hopefully, some of you maybe have tomorrow off and you can go ahead and enjoy your 4th of July weekend. Before we can get started, just I have a couple intros I need to read here. The first is nationally recognized as one of the most innovative and privately owned consulting and therapy management firms, HealthPRO Heritage partners with a diversified portfolio of providers who span the care continuum. They are an indispensable partner to healthcare providers and the residents, patients, and their care because they execute truly innovative, redesigned, and patient-centric care as evidenced by outcomes and fiscal successes. Their mission is to enhance the quality of life of the individuals they serve and foster an environment for all to flourish by providing consistent quality care with honesty and integrity. Amidst all of the recent challenges and changes, they have continued to provide their partners with what's needed to succeed. As America recovers from the global pandemic and sets its sights on the future, HealthPRO Heritage's dedicated team pledges peace of mind and a proactive go-forward approach. Just a quick reminder that HealthPRO Heritage will be putting on a Stay on Track for 2020, a COVID-19 webinar series. We believe that should start around August. This webinar series will cover a wide range of topics related to COVID-19 and how facilities can adapt to a new and evolving updates and opportunities. Topics to include infection control, MDS coding, admission criteria, and more. It's appropriate for DONs, admissions, MDS coordinators, and administrators alike. Today's speaker, Chelsea Lowe, will be the presenter for this series, and she will be offering easy and successful strategies for facilities to ensure compliance and implement best practices. Now, lastly, today's speaker will be Chelsea Lowe, as I said. Chelsea has worked in long-term care for 18 years as a STNA, MDS coordinator, and director of clinical services. She has held regional and divisional roles in reimbursement and enjoys teaching and training others. Chelsea firmly believes that giving teams the tools and resources they need to succeed and to promote positive outcomes within facilities and bettering patients' lives. Chelsea does specific trainings and speaks at the corporate level on subjects like case mix index, quality measures, survey outcomes, and survey readiness. We believe that her content should go around 30-35 minutes, something like that. So if anybody has any questions, feel free to type them in the questions chat or the little questions tab throughout the presentation, and we'll go over those at the end. If anybody would like access to the handouts, you can look at the handouts tab, and there are two handouts. They are both the same exact presentation, just one is a PDF form and the other is a PowerPoint. Other than that, I think that takes care of everything that I need to do, and I will now turn it over to Chelsea. Thank you.
All right, thanks, Blake. Thank you so much. Thank you, everybody, for having me. I'm super excited. And obviously, we're going to talk about one of our topics that the nation has talked about a lot in the last 3 to 4 months, COVID-19. I want us to be able to talk about what our centers should do to prepare for COVID-19. We should be already doing some of the items that we're going to be discussing, and then kind of what does it look like down the road? What other items could we maybe put in place to better our successes with infection control? Obviously, we know infection control is a hot topic. It always played a big part in our annual survey, but now with COVID-19, it's a heightened focus with the COVID-19 infection control surveys. So we'll discuss that at the end. So first, we're going to start about what steps do we need to take as an overview related to infection control. Each of your centers should have a person or persons designated as an infection preventionist. This infection preventionist is going to be a key component in your antibiotic stewardship, tracking antibiotics, monitoring the use of antibiotics, and in your infection control tracking for your surveillance plans, your risk assessment, your emergency preparedness plans, and so forth. So they're going to be the key component, if not the leader, in some of those items. The other thing I want to make sure that we're doing is making sure that we're pulling out those policies related to infection control and the communicable diseases. We're looking those over and making sure they're still accurate and they're still up to date. Also, we need to also include testing. What does the testing look like for infection diseases? Before COVID-19, we did some testing for maybe a wound culture, or maybe we did some influenza A or B testing for during flu season, but we need to make sure that those are kind of incorporated into our policies as well. Our facility assessment, that's nothing new. We should have a facility assessment that is a key indicator for the center on what our current population is, but it should also be updated with anything that's evolved after COVID-19. So has your population changed? What does that look like? What does the needs of the residents look like? And the needs for staffing. And we'll talk about that in the next slide. And then as MDHHS has given forth the instruction to have a testing plan for the center. So those had to be submitted into MDHHS by June 15th, and the testing should be probably conducted in some of your centers already, if not being soon. And then the emergency preparedness plan. Before COVID-19, a lot of the emergency preparedness plan was directed towards fires or hazards or things like that. But with COVID-19, we look at it a little bit more on the infection disease side, and we'll review that as well. So first off, let's talk about the facility assessment. Now, the facility assessment, like I said, is nothing new. We should all have a facility assessment plan. It should be reviewed annually. If it's not due to be reviewed until, let's say, October, November, I definitely pull that out and just look at it, especially related to COVID-19, and make sure that nothing's really changed in that. So the facility assessment looks at your current resident population. It looks at what are the key diseases or related conditions that we care for in our centers. So Center A is going to be totally different than Center B. Center A might have more of your COPDers and more long-term care residents, and Center B might have more of your short-term care residents with infectious diseases. Maybe a lot of them come with wounds that are infected and come on IV antibiotics. So we have to look at our population and what tools and training do we need to properly care for the comorbidities that the residents have in our center. And so whatever conditions or diseases those residents have, what service and care do we need to be able to properly care for those residents? If they're dialysis patients, what does that look like? They don't want individual care plans, but they want kind of a facility care plan on how are we going to care for these residents? What do we need? What kind of interventions do we need? And then what facility resources? So what training does the staff need? What supplies do we need? Is there contracts with third parties, for example, dialysis and hospice? So we definitely need to pull that facility assessment out and just take a look at it. If you have COVID-19 residents, I'm assuming you might have moved some residents around and have a COVID-19 unit. So again, your facility population might have changed a little bit, and that just needs updated and tweaked a little bit. So the testing strategy. So in the state of Michigan, all residents and staff are going to be tested to begin with. When you submitted your testing plan to the state of Michigan, it had to include what laboratory did you contract with for your testing plans. Also working with your hospitals to make sure any new admits are either tested 72 hours or closer to discharge to the center, or they have to be tested when they come in your building as a new admit. If you have a positive resident, making sure that the weekly testing of all residents and staff happen until you are 14 days free of a positive case. So those are just some guidelines that the state of Michigan, the Michigan Department of Health, has kind of set forth. But the other things we want to look on is the types of PPE. So I know that PPE in some buildings are very plentiful, and then some buildings are not. So we have to kind of think outside the box for our PPE and what does that look like for our center. If we're struggling with PPE, we obviously need to reach out to some coalitions and we've had people reach out to churches that they've actually done some gowns that are reusable. So we definitely need to think outside the box for that, but we also need to make sure if there's a shortage of PPE that we're not cross-contaminating. We're not using a gown on the COVID unit and then bringing it out onto the clean unit, because that's cross-contamination, and that just increases our risk for higher COVID numbers in your center. And then staff supporting and training. So we need to make sure that the staff is aware of our policies, especially our infection control policies, and they're comfortable with them. They understand how to care properly for a COVID-19 patient. And that's going to be based on your facility assessment. So if we have a really good facility assessment, we're going to know what kind of staff support we need and what kind of education we need to do for them so they feel comfortable to care for these residents properly. So COVID-19 testing plan, what should that look like? We should have a physician's order for testing. We need to have a plan on how we're going to obtain consents for the testing. And then how often is the testing going to occur for staff and residents? It might just be an initial testing, everybody comes back negative, okay, great. But if you have somebody that has signs or symptoms of COVID, when do you test them? And then what happens when you get a positive case? That's when you're going to initiate that testing weekly till you're COVID-free for 14 days. And then you have to identify a schedule for testing action. Like I said, include laboratories or hospitals that you can partner with to provide the testing for you. So I talked a little bit about our emergency preparedness plan. And our emergency preparedness plan, like I said, before COVID-19, we really didn't include, I would say from what I've seen in emergency preparedness plans, we really didn't include infectious diseases on this, but we probably should have. If we didn't, we should have included influenza, but it was more based on fires, tornadoes, gas leaks, etc. What was our evacuation plan? So those still need to be on there because they're still super important. So if we have to completely evacuate our center, where are we partnered with a local church or a local school that's where we're going to evacuate to so our residents are safe until it's all clear or until we have another place to evacuate from. And then COVID-19, we have to look at emergency preparedness for what happens if there's a staffing shortage. So we might not have one now, but what happens, the numbers continue to rise. So what happens if we don't have staffing to care for the residents? And you actually, the MDHHS has a link that you can reach out to them, and they'll hopefully be able to put you in contact with somebody to help short term with a staffing crisis if it's related to the pandemic. So now we talk about, okay, our facility assessment's in place, our emergency preparedness is in place. How do we track and monitor diseases? So we should have been doing this before COVID-19 even came, but now it's going to be a heightened focus. And I do know on some COVID-19 surveys that they're actually asking to see your surveillance plan. So your surveillance plan can look different in each center. There's no wrong way to do it as long as you hit all the key items. So your surveillance plan is going to help you identify infections. It's going to help you establish a baseline and help you see when there's a potential outbreak that can occur. And then it's going to help you hopefully put plans in place to prevent the spread of infections among residents, staff, and visitors. This is also going to help you put a performance improvement plan in place, and also is going to help you track towards priorities on the annual facility risk assessment. So what do you need to do to develop a good surveillance plan? Okay, so we have that facility assessment. That's going to help us determine what type of population we have, right? And then we're going to review on the next slide how to select an outcome or process measure. We need to educate the floor staff on how to collect data to properly report it to the doctors on any type of infection, any type of abnormality, right? So we need them to feel comfortable. We need to make sure they have the criteria met to actually be put on an antibiotic for antibiotic stewardship. And then it's also going to help us for reporting and use of surveillance information. So it's going to help us maybe complete an outbreak report or an outbreak summary, or it's going to tell us when we probably should be contacting our local health departments for an outbreak. So I told you there was two different types. There's two different types of ways you can measure, and some centers even measure both ways. The process measure, that's a lot of auditing and observation. So you're observing them, you know, performing hand washing, providing wound care. That's a lot of their competencies that they should be doing annually and being checked off on, correct? So we're conducting them through audits, observation, and then the review of the documentation. And we're kind of using our policies and procedures as a guide for the process measure. And then you have the outcomes measure. That is, you're going to do a risk assessment that's going to identify hot topics or hot infections for your center. So let's say I was on a call with a center last week, but they have a lot of UTIs in their building, which I would assume could be a common infection for some centers. So UTIs were an issue. So they know they're definitely going to track that UTIs among residents and staff. They also know that they're going to look at the specific pathogens that were actually used to cause that, and then be able to see if it goes above the baseline, if that's a true outbreak or not. And that's also going to help us establish multi-drug resistant organisms. So if you're monitoring what type of organisms is causing each of these infections, you'll be able to see when you get the multi-resistant organisms, or if you have an influx of those as well. So you have two types of measures, and then you have two types of surveillance. The comprehensive surveillance, I think, is a little bit more the nursing way, because we all have probably a little bit of OCD and want to make sure we don't miss anything, right? We want to do a great job. We don't want to miss anything on the front end. So we want to track every infection on the whole population. But if you have a bigger center, that's sometimes super hard to do. It can take significant time and resources. So some bigger centers might actually do something called a targeted surveillance. So they're going to pick the top 4 infections that they think could cause or that the center has opportunities for, right? And they're going to focus on those 4 infections. So they're going to track their UTIs and their pneumonias and their wound infections, let's just say those 3. And so they're going to track those. I'm not saying they're not going to look at the other infections, but those are going to be the key items that they're actually going to really document on it and report on. And they can go a little bit more in depth on those because they're not tracking every infection in every resident. But I know a lot of us as nurses that are on the call like to just make sure we don't miss anything. So from what I've had conversations with centers, a lot of them are doing the comprehensive surveillance versus the targeted surveillance. So HealthPRO Heritage has a complete infection control toolkit. So if you're on this call and you're like, oh, man, I don't even know what Chelsea is meaning by a surveillance plan. That's okay. We're here to help. And on our website, there's actually a link to go into our infection control toolkit. This is a copy of actually our infection control surveillance plan checklist. So it tells you what type of surveillance program you can have, how to develop a collection process, and then what to do with the data. So you have all this data setting in front of you from collecting from infections, and then what do you do with it? How do you report it? How do you figure out a rate? So this breaks it down. The toolkit has so much more. It actually has an outbreak summary, how to do an outbreak summary that you're going to get from the surveillance plan. It has the data collection tools that you might need for the frontline staff on what to collect to report to the doctor. So be sure to check that out. I think it's a great tool to use, and it's actually a full manual / toolkit that you can just use to help guide you through the infection control process. Okay, so we kind of hit some hot topics on infection control, but now I want to kind of talk about these infection control surveys, what to expect. So, you know, as states start opening up, we don't want to let our guard down. We all know that the elderly are the most vulnerable, right? So we still want to make sure that we're continuing to screen all of our employees as they come in for the day, that we're continuing to tempt those employees. We're also monitoring the residents daily for fever or respiratory systems. I think best practice would be daily. If you have a confirmed case of COVID, we're making sure again that if your layout allows, there's a designated unit for the COVID positive patients, and that staff feel comfortable, on how to properly put on and take off the PPE, don and doff the PPE, and then proper hand washing. I think we can decrease the mode of transmission through hand washing if we can hand wash, when we're supposed to, before and after care, every time we come in a room, every time we come out of a room, and that we have hand sanitizer readily available as well. But we are seeing the infection control surveys. They have to be completed per CMS guidelines by 7/31. So if you haven't seen one, guess what? It's coming. So we need to make sure that our staff is ready for those surveys. And what have we seen with some of these upcoming surveys? Just some pointers that I think will be very helpful is making sure that employees are practicing social distancing with each other. So, I work with Susie Q every day, so it's no big deal that we stand, we sit together in the break room, or we sit together, stand together in the hallway. We need to make sure we're maintaining that 6 feet apart. We're ensuring that the staff feels comfortable properly putting on and off PPE. We're making sure that that face mask is actually on at the bridge of the nose and not at the end of the nose. I know if you wear it for 8 hours, it gets hot, it gets stuffy in there. But if it's at the bridge of the nose, it's ineffective. And we've actually had some surveyors comment on that. So making sure that happens. Hand washing, believe it or not, as much as we talk about hand washing, there's been some concerns on making sure that we're washing for 20 seconds or greater. We're washing in that downward motion. We're getting our nail beds, our wrists, the back of our hands, in between our fingers. We're making sure that we dry thoroughly, and we're using that napkin to shut off the water, and then open the door if possible. And then, like I said before, making sure that staff is able to answer questions on cleaning the equipment. I know that's been a focus. If your therapy department, make sure that you're including them as well in your competencies for donning and doffing PPE, hand washing, and cleaning of the equipment, because they are, if they're not coming to the gym, they might be taking equipment down to administered therapy, and we want to make sure that they feel comfortable cleaning that off afterwards when they're exiting the room. And then make sure that, surveyors are visitors in our building as well, so we need to make sure that they are being asked the questionnaire that we ask all of our employees, and their temperature is taken upon entrance. If they answer yes to any of those questions, they should be told that they cannot enter, and that's okay. Some surveyors do it just to see if we're adhering to the questionnaire and making sure that we're screening everybody before they come in. So those are just some things that I think are very informative, and make sure we're out there observing our residents on a day-to-day basis, especially if you haven't had an infection control survey. And if you have, you never know if they might come back. So we're always prepared for them to walk through the door, and we're always practicing best practices with COVID-19 especially. So again, my name's Chelsea Lowe. I will be doing the next 3 series, as Blake said, and this is my email address. Feel free to reach out if you think you need some further assistance related to infection control or have some questions related to COVID-19. I'm happy to help. I'm here to help. And I hope that this was informative, and thank you so much. Blake, do you have any questions?
All right, thank you very much, Chelsea. I am not seeing any questions right now, but just in case anybody is typing or doing anything like that, trying to ask a question really fast, we would like to say thank you again to Chelsea for being with us as a presenter today. And we would also like to extend a special thank you to our valued business partner, HealthPRO Heritage, for their continued support. And lastly, we would like to thank, I believe we had around 30 to 35 members and participants that took time out of their busy schedules to join us here today. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I am not seeing any questions come in, so thank you everyone for joining us today. I hope everyone has a great holiday weekend, and stay safe.
Thanks, Blake. Thank you so much.